Hello and welcome to the September Digital Health Virtual Program. My name is Matt Rayner. I am the publisher here at Healthcare Innovation. Today is all about the future of interoperability. It's Interoperability Virtual Day. We have 4 fantastic sessions planned for today. And whether you're consuming this content with us here today live or watching this on demand, thank you for being a part of this program. All of our sessions are designed to be interactive. So please do not hesitate to submit your questions for our faculty today by utilizing the chat functionality within the Zoom platform. Our opening session today is a discussion around interoperability innovation during the pandemic and beyond. We'd like to thank our friends and partners at Infor for their support with this session. And I'd love to, at this time, welcome on our editor-in-chief, Mark Haglin, who will be moderating this opening session here at the Interoperability Virtual Day. So Mark, take it away.
Thank you so much, Matt. It's great to have all of you with us, either at the moment or, as I like to say, in the future. Greetings to those who will see us in the future, those who will consume this virtually. Thank you so much for joining us. It's my pleasure to welcome you to this first session. And I am honored to be with Jörg Schwartz, who is a senior executive at Infor. I'm going to begin by welcoming Jörg and asking him to describe himself, his title, and his role in the company. Welcome, Jörg.
Thank you, Mark. So happy to be here with you and looking forward to our conversation. Yes, as you mentioned, my name is Jörg Schwartz. I lived for 22 years in the United States. Originally, I started in Germany and in Europe. At Infor, I'm director for interoperability strategy and solutions. And I'm in the healthcare IT industry for over 25 years. Let's leave it at over 25 years. We don't have to go into details. But I worked at companies like FHIR Healthcare and GE Healthcare, and have been working with a lot of customers in interoperability, from medical image archives to regional and national health information exchanges. So happy to be here.
Welcome. We're thrilled to have you, Jörg. Thank you. So let's plunge right in and talk about interoperability, talk about innovation. What are some of the solutions that are going to drive better patient interaction in healthcare? Where are some of the innovations happening from your perspective?
Yeah, Mark, it's interesting. During the COVID pandemic, we actually have seen a wave of innovation that is unprecedented for healthcare. Normally, healthcare moves at a pretty glacial speed. Sometimes we have some spurs of innovation. For example, the Affordable Care Act obviously created a huge wave of investment. Hospitals wanted to take advantage of the investment program, invested in EMRs. We saw a lot of interoperability also was required. The ACA required for meaningful use that you were able to produce documents in CCDA format, Hl7 v3, et cetera, et cetera. So we've seen spurs of innovation before, but COVID really required hospitals to react very quickly and come up with solutions that allow to interact with patients remotely. So we've seen this buzzword, the digital front door, because hospitals wanted to engage with patients, allow them to schedule COVID appointment, COVID vaccination appointments, but also do teleconsultation visits and all kinds of other interactions that otherwise would have required the patient to come on site, which obviously was difficult during COVID. So they had to figure out ways how to do that during the pandemic. They had to figure that out really quickly.
Yeah, absolutely. I agree with you completely, Jörg. I think one of the interesting elements of what's happened in the pandemic is it has forced innovation of various types, technological innovation and also process innovation.
Yes.
And that leads actually to my next question for you, which is, tell me how you define the quote unquote digital front door, and tell me also how you think the pandemic has shaped innovations in that area, because we're hearing from patient care organization leaders all across the country that it indeed has done so, that consumers are now, they're different from 18 months ago. Their expectations have been raised. And I'll just add one further preface in asking that question, and that is, all of us, especially during the pandemic, have come to a certain place in terms of our consumer expectations in other industries. You know, we have food delivered to our door. You know, we have clothing and other retail goods delivered to our door. We order everything online. We interact with AI-based chatbots. There's so many things we do. And as you mentioned, healthcare historically has been very slow to innovate, but the industry has had to move much more quickly during the pandemic. So when you look at the concept of the digital front door, especially in the context of what's happened during this pandemic, how do you see all of this?
Yeah, you're absolutely right. I think consumers were used to the fact that healthcare is just different than other industries, and that you cannot schedule your appointment easily online. You can look at your appointment after you scheduled it in a patient portal, but if you want to change it or whatever, you have to call a call center. The hospitals operate still large call centers, and it was accepted because we never knew healthcare to be differently. But then during the pandemic, hospitals had to figure out ways, because you couldn't have a lot of people in the call center. You had people that were out and you had to redeploy them. So you didn't have huge call center staff. So they had to figure out ways to allow scheduling online, like you book a table in a restaurant and book your service appointment for a car. And I think that that genie is out of the box now, and people have gotten used to, oh, wow, I can schedule my healthcare appointments online. I can move them online if something comes up and I cannot attend the meeting. And so in my opinion, and also when I talk to customers, they usually see it the same way. That genie is not going back in the box. So customers now expect healthcare to be more user-friendly, and that's what the patient portal is all about. Offer a digital experience for patients. There is, the last place I want to go if I have COVID symptoms is the hospital, right? So I would like to have a teleconsultation over the phone and let the doctor tell me what I should do, which medications I should take, et cetera, et cetera. And we've seen that teleconsultations are now also paid by the payers, similar equivalent to a doctor's visit in person. And all of these things happen very quickly, that payers got flexible and did the reimbursement. The technology is there for mitigating teleconsultation. We've seen customers that even transcribe the teleconsultation using AI and natural language processing, and basically document the teleconsultation automatically. So we see a lot of technologies that have been deployed everywhere now being used in healthcare to make that digital front door and that digital experience for patients happen.
Yeah, absolutely. And one of the things that we'll be talking about in just a second here is technological agility. But I think one of the things that you're referring to here is process agility. Hospitals, medical groups, health systems are having to become more agile, more flexible. One of the things we're hearing is there was a period of time last spring when 80% of healthcare was being delivered through telehealth remotely.
Right.
Then it went back to about 20%, but we're hearing it's hovering above that level, because now that healthcare consumers are more empowered, they are actually wanting to access remote care when they can. So organizations are having to become.
And Mark, not only Mark, not only consumers, I think there's even some healthcare providers that also prefer this.
Yep.
It's also something that has an impact on the providers. They also looking for an alternative to driving into the hospital during
Yeah.
some COVID times, and maybe do a day or two a week where they do teleconsultations.
Right. Absolutely. Absolutely. So what do you see as some of the obstacles to innovation right now?
There's a really interesting paper by Gartner that talks about the EHR mega suite and how the EHR mega suites have become kind of like obstacle for innovation. On one hand side, they consume huge portions of the IT budget because they suck up every dollar that the hospital has. And on the other hand, they really slow down the rate of innovation. So this is an impediment to move fast. And as you know, upgrading to the latest and greatest version of an EHR is a huge lift for a hospital. It's something where you have to train hundreds, if not thousands of people, and it's a major project to undertake. And right now during the pandemic, it's really the worst time to do an upgrade so you can leverage, for example, FHIR capabilities. So we are helping our customers to overcome that problem and take advantage of the innovations that are out there and all the applications for teleconsultation and connect that back with the system that they have in place without forcing them to do upgrades or major changes to their infrastructure.
Absolutely. Absolutely. So let's talk a little bit about FHIR.
Right.
FHIR, Fast Healthcare Interoperability Resources. Tell us how FHIR fits into the innovation landscape and everything that's going on right now from your perspective.
Yeah, it's really interesting. FHIR has become a hotbed for a lot of innovative startup companies in all kinds of areas, be that IoT devices, device monitoring, analytics, analyzing data, and they're basing everything on FHIR because FHIR obviously is a much cleaner data standard. It's much more tight than Hl7 v2, which leaves a lot of variability. And everybody who has been working with Hl7 v2 knows that when you bring data from multiple sources together, there's a lot of work to do if you want to use it for analytical purposes. So with FHIR, a lot of this is much more feasible. You can aggregate the data and you can utilize it. And a lot of these startup companies, recruit people from college, and they are absolutely familiar with FHIR because basically JSON, web services, all the stuff that computer science graduates are learning in school, but they're not familiar with Hl7 v2. So we have this interesting situation right now where the business of healthcare on a day-to-day basis is still transacting hundreds of millions of Hl7 v2 transactions. And at the same time, all these innovative applications that bring patient engagement, that allow patient remote monitoring, et cetera, that go in the population health management space where you identify the gaps in care, et cetera. All these applications are on FHIR, and somehow the problem is, how do you bridge the two worlds? How do you bring them together and help organizations to live both in the Hl7 v2 world and in the FHIR world?
Yeah, I mean, among the areas of activity right now, you've got patient monitoring at home. You've got the whole field of clinical decision support. You've got care coordination, risk stratification work. When you look at that kind of galaxy, and when you look at standards, what do you see right now?
Yeah, so there's the FHIR standard itself, and then within FHIR, there are different working groups. For example, we've been working for a long time with the Da Vinci group, which
Yes.
is defining workflows. So inside of FHIR, you use FHIR as a standard, and then you can define workflows. And Da Vinci, for example, is working on workflows that automate the interaction between the payer and the provider. And this is really interesting. Next year, the Cures Act, for example, requires a digital burden reduction workflow that allows a provider to transmit a prior authorization request to a payer. And then instead of having to wait for several days until the payer reviews this and then sends back a list of documents that they want to see, or a list of clinical data elements that they want to review, this will happen in an automated workflow. So that's something that will speed up delivery of care. It will also speed up payment processes. So it's really a win-win for the patient and for the providers. And FHIR, as an example, is the base technology combined with the workflows that will make that happen. And there's many other work groups within Hl7 FHIR that are working on different workflows. So we're members in Vulcan. We're also members in FHIR, which is a work group that works on data from the ERP, the enterprise resource planning and supply chain side of the hospital, with clinical data to do some reporting on supplies in combination with clinical results. So if the hospital has to how many COVID patients they have and how much personal protective equipment they have, then with the SANER standard, you should be able to automate that process. And we support this with our product suite, with our Cloverleaf product suite.
Yeah, absolutely. Tell me a little bit about the process involved in driving data exchange through FHIR between payers and providers, particularly around prior authorization and other processes. How do you see that?
Yeah, with the Da Vinci workflow, if the payer will have an API for prior authorization, the provider would basically ping that API and say, I need a prior authorization for this patient, this condition. So data that they can transmit out of the EMR. And then the payer would give them back a list of documents that they want to review. And then you can automatically retrieve those documents as FHIR resources. That's if you have a FHIR repository where the resources like demographics, prior conditions, comorbidities, medication, etc. These are all exposed as FHIR resources, and the payer can specify exactly which resources they want to retrieve. And this exchange can happen almost in near real time. And then in the Da Vinci workflow, there might be a window pop up for the provider in the EMR. So in the workflow, that would ask some questions, and the provider that had just 30 seconds ago requested that prior authorization can then answer these questions. And so it's not a week delay and you have to go back into the patient, but you're in the workflow at this moment. It happens in almost real time that the provider can answer some questions that are added to the data that was submitted, and then they can get the prior authorization or the denial right away.
Right, absolutely. How do you think that the 21st Century Cures Act will impact this landscape?
Yeah, I think we had a discussion at our Cloverleaf Solution Summit. We had a discussion actually with the National coordinator for healthcare IT, Mickey Tripathi, about that very topic. And he was very clear that what the government wants is total control of the data for the patient. So they want to give the patient access to all the data and total control of all the data. That's where everything is going. When you look at the rules of the 21st Century Cures Act, as of July of this year, payers have to provide FHIR-based data access for their patients or for their members. And we will have the same requirements coming up next year for providers, and then also the provider payer data exchange, also based on FHIR. So these are the rules, and they are condition of participation. So if a hospital doesn't comply with the rules, in theory, they cannot bill anything to Medicare or Medicaid. And so it's a pretty clear that the government wants this full control. And when you compare this with the patient portals that we got after the Affordable Care Act, what those patient portals did, they created a lot of islands of data that were sitting in different patient portals, but you couldn't really do much with it as a patient because they were sitting on these different islands, and you couldn't really aggregate it. You couldn't do anything with it. With the FHIR-based access for patients, patients can consolidate the data in a platform, and they can decide who they want to give access to the data. So if they decide they apply for life insurance, and the life insurance says, hey, we want access to your clinical data, and here's an app that you can download on your phone, and in that app, we collect the data from your payer and provider, and you submit it to us, and you can have an underwriting process in, I don't know, 24 hours instead of several weeks. That's absolutely, because it's up to the patient to decide if they want to do that or not, right? Same thing with clinical trials. You could imagine that patients can opt in and get matched for clinical trials, and if they want to participate in a clinical trial, they can share data, and they're in full control. And it was very clear that that's what the government wants. That's what Mickey Tripathi wants. He wants the data to flow freely between payers and providers, between providers and between all of them and the patient, the consumer.
Yeah, and I know you had some thoughts around FHIR, the FHIR data store as a staging area, and how we can orchestrate workflow with security.
Yes, absolutely, Mark. I think that's a really important point. So at Infor with Cloverleaf, we developed a complete suite of product. We're not relying on third parties. We developed our own FHIR bridge, which in real time translates between HL7 v2 and FHIR. We just announced our FHIR server that persists FHIR objects, and is a full-featured FHIR server, so you can create subscriptions. You can have provenance of the data, so you can distinguish where the data is coming from, which supports all kinds of workflows on the provider side. And then we have an API gateway that very securely exposes FHIR resources to registered applications. So that allows a provider to build an infrastructure for the digital front door very quickly and very securely. As an example, if you want to utilize IoT devices that patients carry on their wrist, or heart monitor, you can collect that data through the API, persist it in the FHIR server, and then push that data that you collected in FHIR and store in FHIR, push that in HL7 because through the FHIR bridge, so that the existing applications that only understand HL7 v2 can utilize the data. And you want that in a separate data store, because as you push it into the EMR, it becomes part of the legal clinical record. And you probably only want to do that with data that has been reviewed by a provider and that you want to make part of the clinical record. You don't want to put a lot of noise in the clinical record.
Absolutely. What is, we have a question.
Yeah. What's the difference between Hl7 and FHIR?
Which could take a long time to explain, but go ahead.
Well, the easy thing is FHIR is part of the Hl, but they're different generations. So Hl7 v2 that I've been talking about was a standard developed in 1989. So a whole different world. This is before the internet. And I remember that we had implementations with file transfer, and you didn't talk about real-time transformation. You definitely didn't talk about web services in '89. So that's when Hl7 v2 was defined. And then we had later on Hl7 v3 with document standard CCDA, etc. And the latest standard that's about 10 years old, but is really gaining momentum now, is FHIR. You mentioned it before. It stands for Fast Healthcare Interoperability Resources. It's also part of the Hl7 consortium. It's just the latest format, and it's designed for web services and exposing specific data elements. So we call them resources, FHIR resources, through web services, so that an application, let's say you have an application that calculates the contrast medium in a CT scanner, and all they need is the body mass index. So the application could ask for the FHIR resource body mass index, and it would get the body mass index and use that to calculate the contrast medium that they have to give.
Okay, we have time for one more question, and the audience member has asked, when a patient contacts the doctor via telehealth service, how does the doctor access the patient's records? Well, I'm sure that depends on the system, but go ahead, Jörg, if you'd like to explain.
No, I agree. Our philosophy is that the doctor really only wants to use their electronic medical record, and they don't want separate portals or separate user interfaces. So in a telehealth visit, which runs on a separate platform, the doctor should have access to the EHR, be that Epic or Cerner or Allscripts or Athena Health or whatever it might be. But as I said before, the important part is, and that's why we're working with some customers on that, that you record the telehealth session and you transcribe it. And then after the fact, you basically add that transcribed telehealth visit to the electronic medical record. So the doctor doesn't have to sit there and type the whole time the conversation, but can really focus on a conversation with the patient, and the documentation is in the background. By the way, that's a very contemporary concept. We call that ambient technology, where the care provider and the patient don't even notice the technology that is being used. So the care provider and the patient can really focus on a dialogue and an interaction, and the technology in the background has the documentation, the legal requirements basically for the documentation that are necessary. Distracting when your doctor is sitting at the computer behind the computer screen, and you're sitting there talking to the doctor, but you feel like all they do is look at the computer, not at you as a patient.
Exactly. Well, we only have 1 minute left. So I just wanted to ask you, Jörg, could you leave us with a little piece of advice for all those who are involved in trying to innovate in this broad area that we've been talking about? What would you like them to know as a parting thought?
My response to that would be, it's an amazing time to be in healthcare because there's so many interesting new ideas and applications. And interoperability is really, just like it has been for a long time, the enabler that brings all these different modern ideas together and combines them with the existing infrastructure. So my advice is always, do not think first about rip and replace. Think about what you can do with the existing infrastructure by augmenting it with some innovation and use interoperability to make it work.
Absolutely. Well, Jörg, thank you so much. This has been such a great discussion. I know we appreciate it tremendously. And Matt Rayner has returned to conclude our session. Thank you.
Thank you so much, Mark. Great questions.
Excellent. And thank you both for a great session to kick off Interoperability Virtual Day. We are now going to go on an ever so short break. Our next session will be starting at 12:30 p.m. Eastern Time. And that will be a discussion on how interoperability will further transform the future of care. So we will see you back here at 12:30. And until then, thank you.
Bye-bye.